All right. Welcome back, y'all, to another virtual shouting session at Hearts for Health. I hope your week is off to a great start. The month of March is off to a great start for y'all. The year is going by pretty quick. At least it feels like that on my end, but hope it's going strong for y'all. I wanted to give y'all a couple reminders if you happen to be new to our virtual shadowing program. I'll be also going through a little of one of our newest programs unrelated to virtual shadowing called MedTank. But to start off with those reminders for virtual shadowing, especially if you're new, if you've been with us for a past session, you've probably heard this before. But if you are new, just in terms of our format, we have speakers. Today we'll have Jasmine speaking with us about pediatric hematology oncology, but we've had speakers in the past who are also doctors, PAs, nurse practitioners across any specialty, really. Today we'll be talking about pediatric hematology and oncology. Last time we were actually talking about pediatrics. So we get a whole spectrum of specialties out here. Y'all can also feel free to view the past sessions we've had. We've had almost 90. We're near 100. Looking forward to that. But that's the gist of our program. At the very end of these sessions, we will have a Q&A. So each session comes with a different speaker. And towards the last 15, 20 minutes of the session, we'll have some time for a Q&A. If you have any questions for our speaker today, Jasmine, or any others in the future, feel free to drop your questions in the chat. And during that time, I'll read them out so that our speaker can answer them. One other thing I do want to mention about our virtual chatting program is we will keep y'all posted with sessions through either our Instagram or our email listserv, both ways actually. And we go about that usually with flyers. On our email listserv, we include more details about our speaker as well as our other programs. So there is a little more detail over there, but either way works. You can follow us out on Instagram. Our handle is hearts_for_health. The 4 is the number 4. And our email listserv is something that you can email us, DM us, or go on our website to subscribe to. At the very bottom of any page that you'll see on our website, you'll see a subscription form on the left-hand side. Go ahead and fill that out, submit it, and you'll be good to go. But with that said, I do want to move on to a quick blurb about our newest program, MedTank. We are going through a rebranding of this program, so you might hear this program called a different name in the future, in the next week or two. But for now, we call it MedTank. Essentially, this program is sort of a capstone to all of the service-oriented programs we've had in the past. If y'all have been following us for a while, you know that a lot of our programs outside of virtual shadowing are very service-oriented, whether that's non-clinical or clinical. And what we wanted to do is expand this so that any student really could go ahead and create a program of their own. What we do is we have contestants, people who suggest ideas, along with project developers who are people who support those contestants' ideas, join together or be paired together through this program. Contestants will first submit an application. We go through that, and if they are selected, they can go ahead and pitch their idea, sort of an interview, right? And if that's selected at that stage, we'll move forward with the idea, and it will be added onto our roster, is what we call it. At the same time, project developers will apply. They also will be interviewed, and those who are selected will also be added onto our roster. Everyone on the roster communicates over Slack, which is sort of a convenient way to just communicate faster than email. And essentially, the contestants will be able to submit their opportunities to project developers who will be able to select the opportunities that they're interested in. So it's mutual interest on both sides. We would not want project developers to be joining in on projects or service-oriented ideas that they're not interested in. It's mutual interest on both ends. To go through a couple more specific details about each role, contestants are not limited to ideas within just healthcare or medicine. It's service-oriented ideas in general that we're open to. The idea submission guidelines, the specifics on exactly what fits into our criteria are included on the application. And I have the QR codes for both applications listed at the end of this presentation here if y'all are interested. Project developers, on the other hand, have a couple other separate requirements. More specifically, they're expected to commit at least 4 months to being on our roster. And if they are to join a team within those 4 months, or even afterwards, if they'd like to still stay on the roster, which is completely up to them, then they're expected to commit 4 hours per week for at least 4 months once they start their time on the team. Again, these teams do vary based on the actual contestants' ideas, but while those contestants are able to suggest those ideas, project developers are also able to elect whether they want to be participating them in them or not. So mutual interest on both ends, like I said. But here are the QR codes for both applications. Hopefully y'all are able to scan these. If you all are not, feel free to send us an email or a DM. We're happy to share the application links. I know the details for this were presented in sort of an overview. So if y'all have any questions to clarify what I've mentioned or asking about specifics that I haven't mentioned, feel free to, again, email us or DM us. Our Instagram handle, like I provided, is hearts_for_health. And our email is something that I'll include in the video description at the end of today's session. I don't want to take up too much time, though. So, Jasmine, feel free to take it away.
Awesome. Thank you, Michael. Let me share my screen. Okay, and you're still able to see that?
Yep, perfect.
Awesome. Okay. So hi, everyone. My name is Jasmine. I am a current Pediatric Hematology Oncology Fellow at St. Jude, and I'm excited today to give you guys a very broad introduction and overview of the Pediatric Hematology Oncology subspecialty. And so for objectives today, I'll share a little bit of my personal story and path to becoming a pediatric hematologist oncologist. I'll give you guys a broad overview of pediatric hematology oncology as a specialty. I'll describe a day in my life as a pediatric fellow, hematology oncology fellow, which is going to vary depending on which institution you attend for training. We'll discuss a couple of clinical cases, general cases, just to give you a brief introduction. And then I'll also talk about, since I am a few months away from finishing fellowship training, I'll discuss what my next steps are. And so a little bit about me, starting out, I was born in Georgia, but I'm originally from Georgetown, South Carolina. And I might be dating myself a little bit with this picture, but I always show it. Georgetown is considered low country of South Carolina. And so this show, Gullah Gullah Island, it was on Nick Jr. I don't even know if Nick Jr. still exists, but this show resonated with me because they show a lot of the Gullah kind of Geechee culture that is of my family. And so I really enjoyed watching it growing up. I also grew up as an Army brat. My mom was in the military, and so we moved a lot growing up. A not so fun fact, I guess, I attended 5 elementary schools, and that was sometimes within the same state. So a lot of changes as I was growing up. I decided in middle school that I wanted to become an OBGYN specifically. And just as the meme says, I'm going to share a little bit. I started my menstrual cycle at a very early age at 9, which is considered the lower end of normal for starting your periods. And so I had a rough time growing up with that, and realizing a lot of my friends didn't get theirs until like middle school. And so that was my inspiration to become an OBGYN, to take care of other patients like me and other girls like me that may be in the same situation. And so as I went along in life, things changed. And so you're probably wondering how I went from OBGYN to pediatric hematology oncology. And so this is my little brother, Lewis. He was diagnosed with osteosarcoma when he was 14, which is a rare bone cancer. And we'll talk more about osteosarcoma in detail in future slides. But he was diagnosed in 2010, which was my sophomore year, of college. And so when he presented initially, he had localized disease, and we'll talk more about what that means, but ultimately just meaning that his disease was isolated to the one spot in his knee, and they didn't see disease anywhere else in his body. And so he got the initial chemotherapy and surgery that you use to treat osteosarcoma. And then he was fine for about 1.5 years. And in 2012, he unfortunately had lung metastases, which is basically saying that the disease spread to his lungs, which, as we'll talk about later, is a very common area for osteosarcoma to spread. And so this continued to happen multiple times. He would get the treatment, which is surgery to remove it, be okay for a few months, and then more nodules will pop up. And so he got to the point where he was tired of the surgeries. He didn't want to do any more clinical trials because at this point, curing the disease is very unlikely. And so a lot of the therapies are for prolonging life. And he decided that he didn't want any more treatments, and he just wanted to kind of, let things take their course as they were going to. And so in 2016, he passed away at home, surrounded by us, my parents and I, in his bedroom at the age of 20. And so that whole experience, as you can imagine, was very pivotal for why I'm doing what I'm doing now. And some of the things that my parents are also doing on the side, as far as like nonprofits and things like that. But this is what ultimately changed my entire trajectory of what I wanted to do with my career. And so I'll start out by just describing what a pediatric hematologist oncologist is and what we do. And so it is a physician who diagnoses, treats, and manages children, teens, and sometimes young adults who have cancer and/or blood disorders. And so the training pathway for becoming a pediatric hematologist oncologist is 4 years of undergrad training. And then you'll have 4 years of medical school, 3 years of a pediatrics residency training program, and then the stage where I am now, which is 3 years of fellowship training for the subspecialty. And so just to give you a quick rundown of common pediatric hematologic diseases, and a lot of what I'll talk about, there is some crosstalk with the adult side as well, but a lot of these conditions are going to be diagnosed during childhood and get carried on and be transitioned into adult hematology care. But we'll start out with the hemoglobinopathies, which is just a long fancy word for saying that there's some abnormality with the way that the hemoglobin is formed for these patients. And so sickle cell disease is probably the most well-known. And then thalassemias is just another bucket of disorders that have a different type of alteration or abnormality in the hemoglobin gene, which causes these patients to have an abnormally low level of hemoglobin and red blood cells. Then you have kind of the bucket of bleeding disorders. And so hemophilia is probably heard of the most, even though it's a rare disease. Von Willebrand's disease is also, it's actually the most common, but not the one that people think about the most when they think of bleeding disorders. And then you have a group of disorders that are just under the platelet disorders, whether that be that there's a qualitative issue where the platelets aren't functioning appropriately, or there's a quantitative issue where the patient, for some reason, does not have enough platelets. And then you have the group of disorders called thrombophilias. And so these conditions cause the opposite problem as the bleeding disorders. And so these patients have issues with clotting too much. And so they create clots inappropriately and excessively, which can lead to, DVT formation or deep venous thromboses, strokes, and there are other, serious complications that can happen when you are constantly making clots. And then you have the group of disorders that are listed under autoimmune cytopenias. Autoimmune meaning that your body, your own immune system is what we think is targeting your immune cells and causing them to be destroyed or to be decreased in number. And so autoimmune hemolytic anemia, when you hear this, you're thinking about the immune system essentially attacking your red blood cells and breaking them apart and causing you to have less red blood cells, which leads to anemia. It's a similar situation with immune thrombocytopenia, except with when you're referring to thrombocytopenia, this is talking about your platelets. Evans syndrome is essentially a combination of this hemolytic anemia process and then the immune thrombocytopenia. So you have both of those cell lines that are decreased. And then autoimmune neutropenia is similar, except that the cell line that's affected are your neutrophils, which is a type of red blood cell. So those patients are at increased risk for infections when those numbers are low. And then you have bone marrow failure syndromes, which are rare as well. And these are probably the three, I would say, the most common, the most well-known bone marrow failure syndromes with Fanconi anemia, Diamond-Blackfan, and aplastic anemia. And they vary as far as which cell lines are affected. And so specifically for Diamond-Blackfan anemia, that specifically is the red blood cell lineage that is affected. And those patients are essentially not able to create or make more red blood cells, whereas aplastic anemia and Fanconi anemia is more of what we call a pancytopenic picture. Pan meaning that all of the cell lines are low. And so your white blood cells, your red blood cells, and your platelets are all affected. And essentially your bone marrow just doesn't function and it's not able to make these cells that you need. And then I threw iron deficiency anemia in there because it's probably the most common consult that we get as subspecialists. And there are multiple causes of things that can cause iron deficiency anemia, but essentially is a disease that's usually easily treated if the appropriate therapy is given. And so when talking about oncologic diseases, since in our specialty we do end up seeing both groups of patients, leukemia, lymphoma is the first one. I know that comes to mind for most people, and that, again, adults also get leukemia and they also get lymphoma, but the treatments are slightly different and the outcomes are different, where pediatric patients usually tend to do better. And then you have brain tumors, which there are multiple under that list of tumors. We won't go through them in too much detail, but there are multiple groups of them, and they're usually named or defined by the type of cell that the tumor grows from. And so this is the second most common type of malignancy in kids after leukemia are brain tumors. And then we have solid tumors, which encompasses a diverse group of tumors. Neuroblastoma being after brain tumors, neuroblastoma would be the next most common pediatric cancer. Wilms tumor is the most common kidney cancer in kids. Rhabdomyosarcoma is a soft tissue or cancer that develops from the soft tissue, usually the muscle. Retinoblastoma is a pediatric cancer that develops in the retina of the eye. And then you have bone tumors, which we'll talk a little bit more about, that include osteosarcoma, Ewing sarcoma. And this is not an extensive list of all of the solid tumors that we see in kids. These are just a list of kind of the most common. And so now I'll just kind of take you through my medical education pathway and kind of the things that I've done and encountered across during my journey to getting to where I am now. And so starting with college, I attended Spelman College in Atlanta, Georgia, which is an all-girls school. It's a historically Black college. It was the only school I applied to. It was the only school I wanted to go to, even though I gave my mom a heart attack that I didn't apply anywhere else. I don't regret my decision at all. I received my bachelor's of science in biology. I also, while I was there, unconventionally, I joined the Army, followed in my mom's footsteps to help pay for school. And so during the fall semester of my sophomore year of college, this is during that time when I mentioned that my brother got diagnosed. I was actually away at training. And so I was at basic training and advanced individual training from July to December, pretty much the whole semester. And then I came back to school in the spring of my sophomore year, joined the ROTC program. And then when I graduated from college, I was able to then finish the ROTC program and get commissioned as an officer. And so some of the extracurricular things that I did during college, so I did a lot of tutoring. ROTC was enough in itself. So how I found time to do anything else, I don't know, while being pre-med. I did shadow a couple of OBGYNs during college because that was still the mindset was that I was going to be an OBGYN at that time. And then I was also fortunate enough to be able to pledge a sorority for Delta Sigma Theta when I was a senior in college. And then for medical school, just to be transparent, I had a year between college and medical school, not by choice, but because I did not get in the first time. And one of the things I will say was the biggest issue was that I only applied to 4, 5, maybe 6 schools, which sounds crazy, I know, because usually the recommendation is at least 10 plus schools that you're applying to in various different geographic locations. I applied to 4 or 5, all in the Southeast because I didn't want to leave the Southeast. And long story short, I did not get in. And so I took that year and I worked at a bank. It wasn't actually anything medical. And during that time, I actually changed. The only other thing I changed was my personal statement, because my first personal statement was all about OBGYN and kind of my personal experience. And then around that time, my brother had already been in treatments now for about a couple of years. And so my personal statement changed in the fact that I was, spending more time with him and going to his appointments. And, I started to wonder if maybe I was supposed to be doing something else. Maybe that was what I was supposed to specialize in. And so my personal statement changed. I did get a new letter of recommendation, and I applied obviously to many, many more schools. And this particular school, I didn't apply to the first time because I didn't know it existed. It was very new. Our class was the third class that matriculated through. And so long story short, I feel like I always end up where I'm supposed to be. And so I didn't get in the first time. It was a bummer, but I tried again, changed a few things, applied to this school that I'd never heard of that seemed perfect for me and got accepted. And so I attended here and received my Doctor of Medicine degree. There were a couple of programs, and I have links at the end that I'll share with you, but during my first year of medical school, at the end, during the summer between first and second year, I was able to complete an 8-week rotation in pediatric oncology, where I basically shadowed a pediatric oncologist for those 8 weeks. And that is what really drove home the fact that I think this is what I should be doing. And this feels like this is what is meant for me. And so I'll share the link for that program because it was very helpful. And it also gave me a stipend during the summer, which was nice. And then the American Society of Hematology, I did a program with them that was similar. I got a stipend and I was able to complete a clinical research project with a hematologist actually at Emory who was doing primarily sickle cell work. And so at that time, I was also very interested in sickle cell disease. And so that particular program was specific for medical students as well, and was very helpful. And I'll share that link at the end. At this point, I was commissioned as an officer, so I was in the Army Reserve, and so I had required training 1 weekend a month and certain trainings for longer than that during the summer. So I was also attending these trainings once a month, which were paid, which was nice in medical school. And then one of the big extracurriculars that I started in medical school that I fell in love with was volunteering with Make-A-Wish as a wish granter. And I first got exposed to them because my brother had a wish granted through Make-A-Wish to go to Hawaii, which we loved, he loved. And so I wanted to continue, I wanted to feel that and do that for other families. And so I started volunteering with Make-A-Wish, which was a really rewarding opportunity. And then I continued with tutoring and then spent a lot of time at a juvenile detention center. One of my friends actually from med school started this program, and I actually don't know if it's still going on, but she started this program where we would go in and have different sessions where we talked about a variety of topics with the children that were in this detention center. And that was also just a very rewarding experience for them to be able to see us and see what they could be doing, and for them to just ask us questions and get an idea of how we got to where we were and what they could do to get to that stage. So that was another rewarding experience during med school. So I just encourage you to find things that are meaningful to you, college and med school, that you can kind of show just continuity with. Because it's more about quality than quantity when it comes to extracurricular activities, and you being able to fully explain why you wanted to do something and showing that you were persistent and you continue to do it. And so from med school, so as I mentioned, my brother passed away in 2016. I graduated from medical school in 2018. So this was during my third year of medical school. And so I didn't want to be, I guess I just wanted an entirely new space. I didn't want to go to residency training anywhere that I'd been before. I really didn't want to be on the East Coast anymore. It was one of those kind of emotional pulls where I really only applied on the West Coast so that I can just have a totally new environment. And the University of Arizona in Tucson was one of my last interviews, and I fell in love with it. And so that is where I went for my pediatrics residency training. And I had an amazing time during my 3 years there. And so for those who don't know what residency training looks like or what it's for, so after medical school, you decide which specialty you want to receive more training in, or what type of doctor you want to be, essentially. And so pediatrics is 3 years. Many of the residency trainings are 3 to 4 years long. And so that's where you go and you learn about your particular specialty. And then from there, if you want to be even more specialized within that specialty, is when you go on to fellowship. And so during residency for pediatrics, you are doing clinical rotations in the inpatient service and also taking care of patients outpatient. And so you have newborn nursery time, you spend time in the neonatal ICU, pediatric ICU, pediatric emergency department. At our program, you were required to spend, I think it was 6 weeks on the pediatric hemonc floor, and then you had elective time that you could spend in if you were interested in a subspecialty, or if you just wanted to learn more about a subspecialty because you knew you were going to be a general pediatrician, then you had elective time to do that. And so again, I continued on with Make-A-Wish when I moved to Arizona. Each state has their own chapter. Some have multiple chapters depending on how big the state is. And so I continued doing that in Arizona and continued to love it. And I think the fact that I had an ASH award, or the American Society of Hematology award, for medical school, I was also able to get another award for residency to help with funding for a research project that I was working on. And I was actually able to present that as an abstract during my first year of fellowship. And then case reports, so the case reports are fun things to do, and they're kind of helpful ways to just get practice with scientific writing and writing, clinical writing, I should say. But they basically are just patient cases that are unusual or interesting, or something that would be novel, that no one else has written about, or that you think would be helpful to put out there because it's so rare. And so if the more that people report about this, maybe we can learn more about it. And so I did a couple of case reports during residency training that were related to hematology or oncology. And so now I'm here in fellowship. St. Jude was the place that I wanted to go. I felt that it was the ultimate pediatric hematology oncology facility, being that it is the only hospital that's like truly just dedicated to children who have cancer and or blood disorders. And so I was fortunate enough to be able to match there for fellowship. And so I'll be finishing up in June of this year, which I'm very excited about. The first year, and I'll kind of go through what my days looked like my first year, second year, and then now my third year. But during your first year, at least for fellowship, and I think this is across many pediatric hemonc fellowships, the first year is very clinically heavy. It's really hard because the hours are long and it's a very steep learning curve. And so you're completing inpatient rotations covering leukemia, lymphoma. So each of these disease groups has a separate floor. So you're spending time, a month at a time, rotating through each of these services, and you do that twice during your first year. So it's very time intensive and just clinically heavy. And then your second and third year is a little bit better because these are your research years, so it's less clinical time, and it's more time for you to kind of focus on either clinical or more lab-based research projects, because at the end of fellowship you have to have at least one scientific product that you've been able to produce and present for publication. Oops. And then continuity clinic, which I also had during residency, but during fellowship is a little bit more so true of a continuity clinic, because these are actually your primary patients that you pick up throughout your training. So when a new patient gets admitted to the leukemia floor, or when you get a new consult, when you're on consult service about a new patient, you can decide if you want that new patient to be your patient that you follow through all of their training and through all of their treatment, and you manage throughout the duration of their disease process, whatever that disease may be. And so you have this clinic 1 day a week throughout the whole 3 years where you see your panel of patients. And as you go through your first year, you gain more patients. So that list gets longer as you go along, but you continue seeing those same patients throughout your whole 3 years of fellowship, and you are essentially their doctor. And it's a lot more ownership than what I felt in residency training. And so I'm currently participating in this, the FDA and then the AACR is the American Association for Cancer Research. There's this fellowship that I'm participating in now, and it'll make more sense when I tell you what my next career step will be at the end of the presentation. And so just to give you a brief overview of what first year fellowship looked like. So again, you have these inpatient services: leukemia, lymphoma, solid tumor, neuro-oncology, which is our brain tumors, the bone marrow transplant or cellular therapy floor, and then you have the hematology floor. So you're spending a month at a time on each of these services, and you're doing it twice. And so a typical schedule, most days start at 7 a.m. That's when you receive sign out from the provider that was taking care of your patients overnight. And then between 7 and 9, you're pre-rounding on your patients, which essentially just means you're looking at their labs from the morning, reviewing events that happened overnight, looking at images or any new things that have happened overnight that you need to know to be prepared for rounds to decide what the plan is going to be for the patient for that day. And then there are sometimes lectures at 8 a.m. on certain days of the week that you're required to attend as a fellow and required to present at some of them as well. And so usually daily rounds begin around 9 a.m. For all of the patients. And depending on how many patients are admitted at that time, that could last anywhere from 1 hour to 3 hours. And they actually just changed it now to where they're doing walk rounds, which is different than my first year of fellowship here, where we sat and we did table rounds. And then myself and the attending would go see the patients. And so it takes a little bit longer now. And then after rounds, it's taking care of the patients, working on notes, working on presentations that you might have coming up. You find some time to eat at some point. Sometimes you don't. And you just go along with the day with whatever comes up. And I say 5, but that's very flexible. And usually I ended up staying way past 5 for most days. And then again, continuity clinic. You have 1 full day of clinic per week to see your primary patients, where the attending is expecting you to come up with the plan, come up with the ideas of what you want to do to manage that patient. And they are always there to offer you support and to give you their thoughts and their recommendations. And during the first year, you really do lean on their thoughts and their expectations, or their thoughts and recommendations for what should happen next with the patient. But as you progress through fellowship, you do start to become more familiar and more knowledgeable of what needs to happen. And so you end up becoming more independent and being able to make a lot more decisions by yourself, which is expected. And the clinics, just like the floors, are divided by disease type. So you have a leukemia clinic, you have a solid tumor clinic, and the solid tumor clinics are separated. You have a transplant clinic, and then you have a hematology clinic, which, as you can imagine, is not fun for fellows because we're hopping around to each of the clinics, because ideally you would want to have patients, variable amount of patients in each of the clinics. And so 2nd and 3rd year is much less stressful. So you either decide on a clinical research path or a basic or translational lab experience path. And so what I decided upon was a basic and translational research experience, because I had never spent any time in a lab and I wanted to know if that was something I would enjoy doing. And so the days kind of similar, 8 a.m. on those days when I have lectures, I go to those lectures. Otherwise, I'm just starting in the lab. And the rest of the day is just experiments, sometimes patient care, because even though you only see your patients on that 1 day a week, there's always inevitably something else that happens during the week that you need to manage, or that someone's reaching out to you about, working on presentations, and, again, anything else that you need to get done for the day. But I will say that now most of my days I leave by 5 o'clock, which is nice. And then continuity clinic, again, that continues from your first year, and you continue that throughout fellowship. I'd say probably my favorite thing about 2nd and 3rd year is that I've been able to start moonlighting, which essentially, it's different for me because my moonlighting only happens at St. Jude. We're actually not allowed to moonlight at any other hospital, which I prefer because I know St. Jude and I know the doctors there and I know the patients. So moonlighting essentially is just picking up extra shift work for pay, and I like pay, so I do pick up quite a bit. And they're also a good way to continue to keep up your clinical skills when you're in your research years, because you have such less amount of time that you're actually spending with patients. And so just to give a brief overview, I'm not going to go in detail at all about these, what it looks like for my research projects. And so my translational project, I'm actually focusing on how to improve CAR T cells, which we'll talk about CAR T cells, how to improve the efficacy against metastatic osteosarcoma utilizing the chemokine system. And I don't expect you to know what the chemokine system is. If you do, that's great, but we're not going to talk about it. But that's just an overview of what I'm focusing on with my projects in the lab. And then I have a clinical project as well. My lab PI, or my primary investigator, who is usually the attending that actually, runs the lab or is responsible for the lab, she's actually a surgeon, which I never expected, but As you'll learn later when we talk about osteosarcoma, surgery is closely involved in the management of those patients. And so she has an interest in osteosarcoma just as much as I do. So that's how I ended up getting connected with her. But my clinical project is a surgical project, say all that to say. And we're looking to see if there's any difference in how patients do, whether they have a thoracotomy, which is an open chest procedure, versus a thoracoscopy where they use, the little light or, a less invasive way to actually get in there and take out the pulmonary nodules. And whether they be for osteosarcoma or Wilms tumor or any oncologic disease, trying to see if there's a difference between those two procedures. And then again, more case reports, and I won't go into details about those, but these are the three that I'm currently working on right now. And so we'll get into a few cases. Let's see how much time we have left. And they're very basic, broad. I'm not going too crazy with the cases. It's more so just to introduce each of the topics to you guys and show just kind of the typical presentation and how they present these patients on exams. And so a 12-year-old girl, previously healthy, she comes in with a few weeks history of weight loss, dizzy spells, some abdominal pain and vomiting. They got labs and they were significant for anemia, her low red cells, leukocytosis, her really high white blood cell count, and then thrombocytopenia or low platelets. And so this is kind of the typical diagram that you'll see for CBC, which you'll learn once you get to med school. And if you know it before then cool points for you because everybody uses this. But this is what her lab showed. So hemoglobin was 7.2, which normal for a 12-year-old girl is going to be 12 or higher. Platelets were 64,000, which normal for anyone is about 150,000 to about 450,000. And then her white blood cell count was very high, it was 110,000, whereas normal is around probably like 4,000 to 10,000 for the white blood cell count. And so on exam, they find that she has an enlarged liver, an enlarged spleen, and then she has lymph nodes, cervical lymph nodes that you can feel on both sides. And then you can also hear a slight murmur. And so when they looked at her blood under the microscope on the smear, they found these abnormal cells on the smear that were concerning for a particular type of malignancy. And so they referred her to St. Jude for further management. And so in this particular case, this patient is diagnosed with a leukemia, specifically a B-cell leukemia. And that picture wasn't from the actual patient, but just a picture from online that shows what it would look like under the smear. And so leukemia is a cancer of the blood and the bone marrow, and it's the most common cancer in children and teens. And probably when you think about pediatric cancer, leukemia is what you think about because it is the most common cancer that we see. And so it can be divided in two major categories. You have, an acute versus a chronic leukemia, and then can also be defined by whether it's from the lymphoid stem cell or from the myeloid stem cell. And so acute lymphoblastic leukemia, or ALL, can either be from the B cell or from T cells, as you can see here. And so B cell is more common than T cell. And those patients also tend to do better with therapy than the T cell patients. And then you have AML, or acute myeloid leukemia, which receive different treatment, and the outcomes are not as great for AML as they are for ALL. And then you have what's called a mixed phenotype acute leukemia, and those have features of both ALL and AML, and also are a little bit more difficult to treat, but you treat them as if they are ALL patients, so they receive treatment that's very similar to that. And then you have chronic lymphoid and myeloid leukemias, which are both pretty rare in children, so I didn't really go too in depth with that, but you can see the chronic myeloid leukemia sometimes in older kids. And so when thinking about risk factors for leukemia, first bucket are the genetic risk factors. And so trisomy 21 or Down syndrome, patients who have trisomy 21 have this increased risk for developing pediatric leukemias. And then Lee-Fraumeni syndrome is a syndrome that predisposes patients to a wide variety of cancers. And so leukemia is one of those cancers that these patients are at higher risk for. Certain inherited immune system disorders can put you at risk. And then if you have a sibling with leukemia, that has had leukemia, that could put you at a slightly higher risk, even though the risk overall is still pretty low. Environmental risk factors that we think about are radiation exposure. So patients, usually in pediatric patients, you try to avoid, excessive CAT scans or X-rays or anything that has radiation if it's not truly necessary, as that has been shown to be linked to possible increased risk of leukemia. Exposure to chemotherapy or any other chemicals can increase your risk. And then any sort of immune system suppression. So patients who are, specifically patients who are maybe have gotten like an organ transplant and are on medicines to help suppress their immune system so that their body doesn't reject the transplant. Things like that can put you at a little bit of an increased risk for leukemia. And then usually with cancers, thinking about lifestyle risk factors like smoking and drinking, things that we don't typically, see in pediatrics or worry about in children, are not likely to really play a role in the development of many pediatric cancers. And so signs and symptoms of leukemia, a lot of what was in that vignette with that patient. So some fatigue, weakness, headaches, dizziness, the organomegaly that you can feel. And that patient didn't have it, but bone pain is something that's also common, which shows up in children usually as refusal to walk or not wanting to use their legs if they hurt really bad. And that bone pain is just the result of all of those leukemia cells or the blasts just kind of proliferating, which, it happens in the bone marrow. And so the bones are just kind of filled with those leukemia cells, and that causes pain. And so with diagnosing leukemia, first thing for anything medical, physical exam and history are really important, including vital signs. And then specific labs that we would get, I won't go too much in detail about what they are, but just looking at the blood cell counts, and then also numbers that would tell us if the cells are breaking open at an excessive rate and spilling out certain electrolytes. And then uric acid is one of the big ones that we look at as well. The peripheral smear that I showed earlier of looking at the cells under the microscope to morphologically see what they look like. And then bone marrow aspiration and biopsy is required to fully diagnose leukemia. And then we'll often get a chest X-ray because some leukemias and lymphomas can present with a mass in the chest, and we'd want to know if that was there. And then treatment includes a combination of chemotherapy. Newly targeted therapies are becoming more common across a lot of different cancers, and immunotherapy as well. And then for some patients, those patients who are refractory or relapse, bone marrow transplant is an option. And then I didn't include cellular therapy on here, but we'll talk about CAR T cells a little bit. And so thinking about prognosis, the 5-year survival rate is about 90% for patients who have ALL, which is great. And it has gone up extensively over the past few years with the advent of all of these new types of therapy. For patients with AML, as you can see, the survival rate is much lower, so 65 to 75% for those patients. And then in both scenarios, if the disease relapses or is recurrent, then those survival rates drop significantly. And so case number 2, and I feel like I'm going too slow, so I'm going to speed it up a little bit. There's a 21-year-old male, has a lump on his left knee, complains of a little bit of pain, but nothing extensive. Got labs done, nothing was abnormal in the labs. His exam was significant for just this painless, palpable lump on his left knee. And so there's an X-ray that's gotten, and you see this finding that's concerning for malignancy. And so this patient gets sent to St. Jude for further workup and management. Very basic. Usually how osteosarcoma presents. It is the most common primary bone malignancy in children, even though it is a very rare cancer in kids. In kids, it's a primary bone malignancy that you will see. Ewing sarcoma is the second most common primary bone malignancy that you'll see in children. Most of the tumors, most of osteosarcoma tumors are going to develop around the knee. So you're looking at distal or lower femur, or proximal or upper tibia is where most of those lesions are going to develop. And then you can have the next most common site after that will be the proximal humerus. And then for Ewing sarcoma, same, still in the long bones, but it can occur really anywhere along the bone versus osteosarcoma, which is mostly at the ends of the long bones. And then the other thing that's unique about Ewing's compared to osteo is that Ewing can start in the bones or it can start in nearby soft tissue. And so often you're trying to, when you have a bone lesion, these are the two kind of big diagnoses that you're trying to decipher between to determine which one is most likely, and location and where it's coming from can give you a lot of answers to that before you even do a biopsy. And so to talk more about osteosarcoma, risk factors, so between the ages of 10 and 30, those patients are at the highest risk of developing osteosarcoma. And that is thought to be because of the second thing as well with height. During those times of extensive, growth or growth spurts, so we think about more like adolescent, teenage years, patients that are tall for their age or just growing really fast, that increases your risk for osteosarcoma. Race and ethnicity, with osteosarcoma being more common in African Americans. And then if you've had any sort of radiation to your bones for any reason, whether that be to treat some other cancer or any other kind of indication for you to need radiation, then that can lead to you developing a secondary malignancy with osteosarcoma. And then there are different inherited cancer syndromes that can put you at risk for developing osteosarcoma. But most commonly, it's sporadic, and we don't know the reason or the cause for it. These inherited cancer syndromes are pretty rare. And then signs and symptoms are kind of what we just talked about. That patient, some bone pain, sometimes they don't have pain and they just have a lump that they feel over their bone, or they have some sort of limping or walking problem, or they can sometimes present with a fracture, an incidental fracture. And so diagnosis, again, physical exam and history, lab tests, which usually for osteosarcoma, your labs are going to be normal. Imaging studies are the key here. And so this is just, again, these are just pictures from the internet, not my actual patient, but the MRI showing here that finding that we saw in the X-ray. And then this is just looking at the CT of the lungs of a patient that has metastatic osteosarcoma. Again, that's the most common area that it's going to metastasize to. This is a PET scan looking at the uptake of a certain a scan that just looks at metabolic uptake. And so if there's increased uptake, that makes you more suspicious of increased activity or increased cell activity, which makes you think more of a malignancy. And so as you can see in that area of the left knee, there's that increased uptake of the dye. Tissue biopsy is, you have to have a tissue biopsy to fully diagnose it. And then staging comes after the diagnosis. And so localized tumor is only in one place. So it's localized just to that area of the bone where you found it. And you don't see anything in the CT scan and no other areas on the PET scan that are concerning for disease. And then metastatic disease is that it has spread to other places, whether that be one place or 2 or 3 other places. It just has to spread to one place to be considered metastatic. And again, the most common place for osteosarcoma is the lungs. And so treatment for osteosarcoma is a combination of chemotherapy and surgery. And so these patients, now it has progressed a lot. And so now patients can get limb-sparing procedures where they are placed, prostheses are placed so that patients still have pretty good function of their leg and are able to walk and still aesthetically have their leg not to be, it looks like their normal leg essentially versus getting amputations, though some patients still require amputations depending on the clinical case. And then there are more, targeted therapies that are being studied for osteosarcoma as well as other cancers. And so 5-year survival rate for just localized disease is only 65 to 70%, which is not great. And so with metastatic disease, it drops much lower to about 30% for these patients. And so to talk about CAR T-cell therapy, I don't know how much you guys have heard about CAR T-cells, but the CAR part stands for chimeric antigen receptor. And so this is the genetically engineered portion of a T-cell that contains a protein that's going to help the cell more readily recognize specific antigens that tumors are expressing so that the T-cells can then find those tumor cells and kill those tumor cells more effectively. And so for leukemias, and lymphomas is where this has really taken off. And this is just to give an overview of what the process looks like for CAR T cells. So you're taking a patient's own T cells from their blood, and you're inserting that gene that's going to help that T cell to express that receptor so that it can better recognize the tumor cell. And so you create the CAR T cells and then you grow them out in vitro. And then you're going to infuse those CAR T cells into the patient once you have enough. And then the idea is that those CAR T cells are then going to be able to attack the cancer cells much better now that they have this receptor that is very specific for whatever this CAR or whatever the cancer cell is expressing. And so these are just a list of the approved CAR T cell therapies that are out there now. And I wanted to just highlight that there's only one for kids, and that's Kymriah, and it's specifically for B-cell ALL. And it has proven to have really, really great effects and has helped in the refractory and relapse setting for those patients. And so when thinking about CAR T cells for solid cancers like osteosarcoma, which is what we're working on in the lab, there are a lot of different barriers that come to mind when making CAR T cells effective for those malignancies. And so antigen dilemma is one of them, being that solid tumors, they all express, they have a heterogeneity of expression. And so even within like the same patient, pre-treatment and post-treatment tumors have different expression of antigen. And so trying to figure out the appropriate antigen to target is one of the issues. Having T cells to be extremely fit and being able to last in those chronic antigen exposure areas with solid tumors, where they have to consistently try to kill the tumor cells kind of in this big rock of cells, is also an issue for CAR T cells. And then the environment within solid tumors is very immunosuppressive, and it doesn't support the survival and function of T cells. And so that is another barrier. And then the last thing that we're working on with the chemokine system is trying to help T cells actually find the tumor cells better, and then also being able to penetrate the tumor cells so that it can effectively do its job. So there are multiple things that just make it harder for CAR T cells to work as well for solid tumors as they do for tumors that are in the blood. And so this last case, I'm just going to speed through because I know I'm probably hitting the hour mark. But this is a 22-year-old male, a true patient of mine that I feel encompasses everything. So he had osteosarcoma, also has sickle cell disease, and he presented for evaluation for transplant for sickle cell. And so his osteosarcoma, he actually presented with metastatic disease, completed all of his therapy and didn't have any issues, no recurrent disease or relapse, and had been off therapy for about 5 years at the time of evaluation. And once you hit 5 years, the risk of you relapsing is extremely, extremely low. So we consider him cured. Sickle cell history is very extensive and complicated. He's had multiple complications, just to summarize that, which is why he was a candidate for transplant. And so the available donors that he had was a sister with sickle cell trait, and then his mom and dad who also had sickle cell trait. He has an older brother who has sickle cell disease, so he was not an eligible donor for him. And so just to briefly talk about sickle cell disease, because that's the largest hematology population of patients that we see. It's a blood disorder it's an inherited blood disorder that affects the red blood cells specifically. And there is a gene mutation in the hemoglobin gene that causes the cells to not form correctly. And so the red blood cells become this sickled shape. And because of that shape, they easily get caught in the blood vessels, which leads to a bunch of different health issues, as you can imagine. And so just to give you an idea, it is a rare disease. It affects about 100,000 individuals in the US. And to be considered rare, it has to be less than 200,000 people. The risk factors, so race and ethnicity, African descent is the most common. Many of the people who have sickle cell disease are going to be of African descent, but you do have patients of these other races and ethnicities that can have sickle cell disease. And you have to have two parents. Each of the parents have to have sickle cell trait in order for them to have a child, potential of having a child with sickle cell disease. And so for diagnosis, all newborns in the US, this is not globally, in the US are tested for sickle cell disease with newborn screen. So we essentially should know when the patient is born if they have sickle cell disease or not. These are the signs and symptoms that you can see with sickle cell disease because it can cause anemia, and because of those red blood cells being broken open, these symptoms are all a result of that. And then treatment and management, we won't go into too much. A lot of it is just managing and not really treating. So hydroxyurea is a medicine that helps change the hemoglobin to a different form so that the cells, the red blood cells last longer in the blood. We give penicillin prophylaxis or antibiotics to these patients because their spleens over time, what we call autosplenectomized, meaning that their spleens just over time stop working because of all of the cells that kind of get caught in there and cause injury. And then blood transfusions, when they become really anemic, usually when they become sick or have other triggers, their red blood cells can really start to break open, or they can have really bad anemia. Bone marrow transplant is something that's new, and right now is the only viable option for cure for sickle cell patients. And I showed this patient because she was a St. Jude patient who had AML and also had sickle cell disease. And when she got her transplant for AML, it also cured her sickle cell. And so St. Jude likes to make sure everyone knows that the first patient with sickle cell disease that was cured with a transplant was a St. Jude patient. And we actually do have trials, and we transplant quite a few patients now for sickle cell disease. And then recently, I don't know if you saw, but the FDA approved gene therapies, the first gene therapies to help treat patients with sickle cell disease, which is a big deal because this could be another avenue or approach to hopefully provide a cure for these patients. And so I just show this to show that complications of sickle cell disease affect every single organ system, and these patients end up having chronic, lifelong medical problems because of this disease. And then briefly talking about transplants. Sorry, guys, there are a lot of slides. Allogeneic transplants basically means you're getting your cells from someone else. Autologous transplant means that you're getting the cells from yourself. And so those are the two kind of buckets you think about with transplant. And then the general process is pre-transplant testing to make sure that the patient is actually a good candidate, collection of stem cells from either the donor or the patient, conditioning, or usually which involves chemotherapy or some form of radiation to help basically clear out the bone marrow and to get rid of everything so that there's actually space to put the new cells in. And then you infuse the cells through the veins, much like a blood transfusion. People usually think it's much more involved, but it literally just goes through the vein. And then the cells travel to the bone marrow and they start to make healthy cells, which we call engraftment. And then from there, you're kind of just giving a lot of supportive care to manage for side effects and to prevent infection while the immune system is reconstituting itself. And so the indications for transplant, malignant disease, as we know of, so for like leukemia, is the most common reason for getting a transplant. And then certain solid tumors will require the autologous transplant, or the one that I mentioned is from the cells of the patient. And then you have non-malignant reasons to get transplant, with sickle cell disease being the reason that we're talking about today. And so for sickle cell disease, again, it's the only curative option that we have currently. However, not all patients are going to be eligible. In patients it's indicated in patients who have severe complications from sickle cell disease. So as I listed off those complications for my patient, you have to have, and it really doesn't take a lot for it to be considered severe because of how, again, how much it can affect all of the organ systems in the body. And so it's only indicated if the benefits outweigh the risks, because transplant itself is not benign, and there are a lot of severe complications that can come along with a transplant. And so the availability of a donor, which ideally would be a fully matched sibling, is an essential requirement, of course, for transplant. And alternatively, you can use haploidentical, which are usually going to be your parents, or someone who's matched but unrelated to you, which you would have to get from a donor bank. And so I always end with saying this and pointing out that for Blacks or African Americans, we have the lowest odds of finding a match through any sort of donor registry. And so I always encourage people, if they can, to just sign up at Be the Match to be on the registry, because you never know if you might be that person. I actually got called to provide a transplant for a patient for aplastic anemia, but their clinical situation ended up changing. So it does happen. So I just encourage people to do this, because a lot of African American patients aren't able to find the matches that they need for a lot of these conditions. And then I'll end this by talking about my future career plans. I will actually be working at the FDA starting in June. I made a personal decision that taking primary patients was a lot for me emotionally because of my personal connection. And so I was looking for a different way to be impactful, but not drowning or like draining myself mentally and emotionally. And this opportunity presented itself to me. And so I'll essentially be reviewing investigational and new drug applications for solid malignancies, specifically sarcomas. And so I don't go through all of these because I know I'm going over time, but that is what I will be doing. And this is the advice I always give: major in whatever you want to in college. I don't know if you guys are already in college or high school, but major in whatever you want, and you will still be able to do pre-med and take the classes that you need. Extracurricular activities, quality over quantity. No one wants to see that you've done 10 different things if you only did each of them one time for like 30 minutes. So quality definitely over quantity. Shadowing and more shadowing, just so you know what you like, and so you can really get a feel for what you think you want to do or what you're going to get into. And then comparison is the thief of joy. So don't even start comparing yourselves to other people or comparing scores or anything like that, because you are an individual, you are unique, and you bring something different that no one else can bring because you are you. So do not compare yourself as best as you can to anyone else that's trying to follow the same path as you. And then these are just the links for I don't know if you'll get these slides or not, but these are the links for the programs that I mentioned that I participated in throughout my training, if anyone was interested. And I think that's it. But I'm sorry, I feel like that went way over the hour. But if we have time for questions, I'm very open to taking any.
Absolutely, absolutely. And no problem. We love to see the cases. A lot of students ask about them. A lot of students write about them on our quizzes, saying that they're the most exciting part. I did learn quite a bit. I'm sure a lot of students did too. I didn't hear about CAR T therapy. Really interesting way to approach it. You usually think that cancer is tackled more by like external forces like radiation and all, but actually having the body do its own fighting. Didn't think about that approach. I guess there's a lot of ways to approach it.
Absolutely.
But I guess to start off questions, one of the first we have is knowing that you're in a specialty. I guess it would be interesting to hear your perspective on how continuity of care in primary care differs from specialty care. A lot of us hear about primary care and continuity of care. They're very tied in, but based on the cases you were talking about, and especially you mentioned the continuity clinic, right, in fellowship, it sounds like that's the same case in specialty care.
Mm-hmm. Yeah, and so I think I feel like for pediatric hematology oncology, we're almost like general pediatricians in a sense, because once our patients are our patients, they come to us for everything, even runny nose, cough, any sort of symptom whatsoever. Even if we think it's a general pediatric problem, we end up taking care of it because when they're actively getting therapy with us, anything that happens with them is concerning. And so we always tell them to call us or let us know first. And so I feel like out of all of the other subspecialties with pediatrics, it's very chronic. Like usually what we're treating with them is going to be a year's process. And it's not just kind of a quick visit where we see them maybe once or twice a year and that's it. But it becomes this kind of where we're seeing them more than they see their pediatrician. And so I always say, I joke that I'm their pediatrician and their oncologist because I have to take care of all of the general peds things as well while they're in our care, because the families are going to think everything that's wrong with them is related to their cancer or their blood disorder or anything they have going on. So it is a little different in that sense, and each subspecialty is going to be a little different with how much continuity they have with patients, depending on what they're treating. But I think overall for us, our patients end up being with us for years. So it definitely is more of a continuity type relationship.
And I'm sure that's really special in pediatrics, just with the personalities of the patients, and also hard at the same time, I'm sure,
Yeah.
like you said
Yeah.
earlier. Our next question is sort of on the same topic of what I mentioned with CAR T therapy. Students asking, how do doctors determine which treatment is best for patients, whether that's CAR T therapy, normal chemotherapy, gene therapy, and so on?
Oh, great question. So for the most part, most of the cancers are going to have a standard protocol that you always start with to treat. And so a lot of the like gene therapy, CAR T cell therapy, transplant, for many patients, those are usually introduced in the refractory or like relapse setting, whereby you've started the standard therapy and either the patients are not responding to that or they responded, but then their disease came back. So now you have to treat them with something else because what normally works didn't work. And so usually you follow that standard of what is considered the standard of treatment for this type of cancer. And if a patient doesn't respond or they initially respond and then the disease comes back, that's when you start thinking about, okay, is this patient a candidate for transplant? Should we do CAR T cell therapy first? Or gene therapy is really new and not a lot of diseases have them that are like for sure approved that we know works for patients. But deciding between CAR T cell therapy and transplant are kind of usually the big ones when thinking about leukemia. And usually it just comes down to CAR T cell is a little bit, usually we go to CAR T cell therapy first before going to transplant, just because transplant is a tough process. And so if you could avoid that, then it's always good. But some patients end up needing it and some patients end up being cured after transplant. which is great. But CAR T cell gives us an opportunity to try something that's a little less intensive, I would say, on the body of a process that could still lead to a long-term cure for some patients. And so you see that more, I would say, with the leukemias, but solid tumors is where it gets to standard didn't work. So now we need to figure out a lot of different kind of clinical trial, newer drugs that we could try to see if it works.
Interesting. Interesting. On a separate note, at the end of today's presentation, you mentioned how you're going to go on to the FDA as opposed to one-on-one clinical practice. I don't think that many students, I mean, this is, I guess, a factor of shadowing, right? If you're shadowing, at least in person, it's usually with someone who's one-on-one with patients, so you don't get as much exposure to the other career paths. But what other career paths do you see, specifically in pediatric hematology oncology, outside of one-on-one practice and working in industry? Are there any other options?
Yeah, no, that's a great question. And I honestly did not know the FDA opportunity was a thing until literally last year, a fellowship. And so these are things people don't really tell you, and you're not going to find out about, honestly, until you're actively in the training and can just talk to different people. But for pediatric hematology oncology, if you're not doing one-on-one, primarily clinical work, you have the option of being primarily research-based. And so when I joined the lab, I initially thought maybe that's what I wanted to do if I liked it, but I didn't. I don't like the lab. So I decided I didn't want to do that. But there are people who are primarily based in a research lab, and they spend 1 or 2 weeks a year covering an inpatient service as their clinical time. So you have that. You have, as you mentioned, industry, working with a pharmaceutical industry company. The FDA gives you quite a wide variety of things that you could do, but specifically for me, focusing on drug development. They also have a department that focuses on CAR T cells, so cellular therapy, working on developing those therapies. Devices, medical devices, everything we use from like CT scans to lab tests, all of those things. There are people that regulate all of that as well. And so there are a lot of different opportunities to be involved as a physician from those standpoints. I would say those are probably the biggest buckets. So either primarily clinical, primarily research, industry, or government, like the FDA, are kind of the 4 big buckets.
That's really interesting.
Mm-hmm.
Very interesting. I guess we can just end off with 2 more questions that we have. The first of which is, when you were applying to fellowship, or maybe even before, if you made this decision before, were you considering other subspecialties in pediatrics?
No, I would say I was very, since med school, specifically since my brother died, I was very like blinders on pediatric oncology specifically. So I never thought about anything else after I decided that's what I wanted to do. So everything I did was kind of trying to prepare me just for that path. But there are people who switch or who change their mind, if people are wondering about that, because I had friends in residency who weren't sure. They knew they didn't want to do general pediatrics, but they weren't sure about what subspecialty. And some people do decide, kind of at the last minute, or they decide on something and then they change it. Even in medical school, you could say, I think I want to go into pediatrics, and then your last year decide, you know what, I think I want to go into surgery. And so nothing is set in stone. Some people like me just know when you have like a personal reason, or there's something that's really driving you towards one specific thing, but not everyone knows, and that's okay. And that's what a part of the process is, also figuring out what you like and what you don't like, and figuring out what's going to work best for you as far as, work-life balance and all those things come into play when you're thinking about what specialty you're interested in. But I personally was very, very tunneled into pediatric oncology.
All right. Well, to end off today's session, our last question is about the line of work in the FDA. So if you were to work in the FDA, would you have the option to still have some extent of one-on-one patient care? Do they offer that hybrid flexibility?
Yeah, no, that's a great question, because that was something that I was also interested in when I interviewed, because I don't want to completely not ever see patients, because I love seeing them. It's just that it also tears my heart open when I see them and they're not doing well and when they pass away. And so I still want that patient connection without the responsibility of or the ability to even like develop these years long relationships with families and patients. And so you do have the opportunity at the FDA to have what they call professional development time, so up to 8 hours a week. On your FDA salary, they'll pay you to still go work at a clinic for a day if you wanted to go cover a clinic. For me specifically, I'll be actually contracting with St. Jude to just come back and moonlight, do a few shifts at St. Jude a few times a month to keep up the clinical skills. But they do give you the opportunity to continue having some clinical connection. And it's helpful, honestly, for the job to still have a hand in on the clinical side, so that you can actually know what's happening in the clinical side, because that translates a lot to what we see coming at our desk with, the clinical trial proposals and things that people are wanting to try to treat certain diseases. So it's still good to know what's happening clinically, because it will, I think, just better prepare me for being able to do my job at the FDA appropriately.
I know we said that was our last question, but one more that I actually always wanted to ask. So you went through fellowship and you still are in fellowship at St. Jude's, right? And I'm sure like that might be one of the best places to end up for fellowship in your specialty. What is it that makes St. Jude such a renowned place for hematology oncology? And it seems like it's even more specific than that. Pediatric hematology oncology is what their focus is, right? Is it as simple as research funding, or is it more in depth of a reason?
Um, So I mean, I'm biased, but it's a really special place. So again, it's literally all children. So I mean, there's no adult. Usually with many children's hospitals, they're connected to an adult hospital, or there's the cancer center at least, or there's some sort of connection with the adult side. But the hospital is literally just dedicated to children, teens, young adults. So that is in itself just makes it extremely unique. I think the funding, so the amount of fundraising and support that gets poured into St. Jude and what they actually do with the funds is just phenomenal, because our families that travel far, we have housing on campus, they stay on campus. No one pays for food. Like, they come and they eat in the cafeteria. Like, everything is covered. We pay for gas for parents that are traveling or commuting. It's just that the whole setup of it is just to make this entirely stressful and terrible situation for these families as easy as possible. And I think they do such an amazing job of that, with the housing and with the paying for food and covering travel and things like that. The research, again, it's all focused on pediatrics. So there's no kind of sharing of the resources with the adult side, if you will. Like, it literally is all just dedicated to kids. And that's what really, really drove me to wanting to go to St. Jude, besides everyone just knowing St. Jude for what they do and the commercials and whatnot. But it truly is a magical place. And I think families really do feel, just so grateful to be there. And it shows when you're taking care of them, that they just feel comfortable, and you can kind of see that they have this weight kind of taken off of them a little bit, knowing that they don't have to pay for anything. And, insurance isn't an issue at St. Jude. We call it the Disney World of hospitals, because it's different than practicing at any other hospital in the US, because we don't have to think about things like, will the insurance cover this for this patient or what, because it's going to get covered at St. Jude. So it's just a different place. And I think, everything about it has been exactly what I wanted it to be. And so I'm very grateful that I've been able to train here and meet some of these, the world's experts in these diseases, who I'll have these connections with for the rest of my life. So I think it's a great place. I can't say too many good things about St. Jude.
Yeah, I mean, as you were explaining it, even before you mentioned the Disney World reference, I was thinking Disney World all the way, like, especially
Yeah.
since it's, pediatric and all, definitely fits the bill. But that will wrap it up for today's session. I do have one quick thing to say to our shadowers, and that is in the chat box, the same one that y'all have your questions in. We do have our quiz sent in there. It's pinned at the top of the chat, so you should see it in purple or so. It's a Google form link, 10 questions. If you have 6 or more correct, you'll pass that, and we'll be sending in a certificate automatically, should be sent automatically to the email address that you list on the quiz. Be sure it's one that at least we prefer is personal, and a personal email address, just because school addresses tend to filter out things. to spam. If you happen to not receive it in your inbox, though, I do recommend checking spam. And if you don't happen to see it there, go ahead and send us an email. I've included our email address in the video description. Speaking of which, the quiz link is also there, and it's also on our website. So you have 3 places where you can find it. That will be due on Sunday, March 10th at 11:59 p.m. Central Standard Time. So around a week from now, 6 days to be exact. And again, if y'all want to follow us for more, we have these flyers posted on Instagram, on our listserv. We'll be having some more sessions this spring, and we'll keep you in the loop with what specialties those will be in. But I do want to give a huge shout out to Jasmine for getting together this wonderful presentation. If y'all are curious about the links that she included at the end of her presentation, there were 3 links or so. Feel free to send us a DM, an email, contact us however you'd like, and we'll share those with y'all. If you'd like the whole set of slides, if Jasmine is okay with it, we can also share those.
Yeah, and I meant to include my email, but please, if anyone has any questions or just any comments, feel free to email me. And feel free to call me Jasmine. You don't have to call me Dr. Smith, even though I appreciate it. But I don't know how to give, if you could give them my email, Michael, I don't know. But I'm more than happy to answer any other questions.
We really appreciate it. I just posted the email in the chat in
Okay.
case you want to check it out. Thank you so much, Jasmine. We really appreciate when speakers share their contact info so that people can get in touch. There's a lot of interested shadowers, especially for pediatrics. It just takes a certain spirit, right? Certain eager spirit, energetic spirit to like the specialty. And there's a lot of pre-meds out there who are just like that. But again, thank you so much for your time. Let's hear some thank yous in the chat for Jasmine for taking the time to get this presentation together and for such a wonderful session. But I know it's a Monday night, so I hope you'll get some good rest. And